thank you so much for joining us for our last event in the Spring Symposium, the Step 1 Renal Pathology Review with the one and only Dr. Mirza. I know how confusing nephrotic versus nephritic syndromes can be, so hopefully we'll make it easier for you. I am Ahmed Afifi, one of the social media coaches. I'll be moderating the chat questions as we go along. I'd also note that you'll be able to access the recording of all our Spring Symposium events on our website, virtualpathsig.org. Now I'll let the rest of the PathSig board members to introduce themselves.
Hi, everyone. I'm Nisa Quintanilla Arteaga. I'm the president for PathSig and a third year at Loyola Stritch School of Medicine.
Hi, everyone. My name is Jenna Angst. I'm a second-year medical student at Lincoln Memorial DeBuss College of Osteopathic Medicine in Knoxville, and I'm the vice president of PathSig.
Perfect. So without further ado, please, Dr. Mirza, let's begin.
Hey, everyone. It's nice to see some familiar faces from yesterday. Again, thank you to PathSig for putting this on. As one of the co-founders, I'm so proud of all of the amazing stuff you do. And if you guys haven't checked out the website, please check it out. It's spectacular. So here is Renal Pathology Review. I owe these slides to Ahmed, who put them together for me, including these cool graphics. And so all of that spectacular stuff is him. Nephrotic versus nephritic syndromes, if I'm supposed to clarify for them for you, fingers crossed, hopefully we'll get through it together. But the kidney is pretty incredible, and learning more about the kidney, I found, is learning more about the physiology of the kidney. If you understand the physiology of the kidney, it's kind of easy to put together the pathology of the kidney. The other thing I'll say about the kidney in step 1 questions is that it is high yield because it can kind of put together a bunch of clinical scenarios that can come across as renal pathology questions. And so in that sense, often you may not even need the histology to answer the question because you'll kind of have values that will give you, or the clinical vignette that will give you the answer. But either way, it's very nice to be able to tell certain things because those are high yield points that are visually very important. And hopefully we'll get through the bulk of this. Remember, this is a 50,000-foot kind of broad, quick overview of renal histopathology and kind of step 1 related questions. So I encourage you to look at other resources so that you get more information as well. So that we'll start with the kidney. And I mentioned, obviously, that we need to understand the physiology, but really we start with the anatomy of the kidney, the normal histology. So we know that it's divided into 2 pieces. It's mainly into the renal cortex, right? This is the outer edge here. You can see it, this little tiny little rim over here. And this cortex, it shows both the convoluted tubules, and these convoluted tubules on histopathology show up as these tightly packed kind of tubules, which are back to back, right? And so most of this just looks pink. The nuclei are blue. It doesn't look like, this is a normal kidney, so it doesn't look like there's any inflammatory cells or anything. And the other piece in the renal cortex are the renal corpuscles. And the renal corpuscles, you typically recognize at this low power as these round structures, right? And so we can all pretty much pick up quickly that those are your glomeruli. So the cortex is kind of on the outside, and it obviously, interacts with or is juxtaposed next to the renal medulla. The medulla shows mostly the loops of Henle and the collecting ducts and the interstitial supportive tissue. And it's important to remember because the supportive tissue has the vasculature, right? The vasculature can be important, obviously, in naturally providing blood supply to the kidney, but also, the interstitial tissue could be the place where there is inflammation. It could be the place where there are tumors. So always remember that when you're thinking about an organ, you have to kind of know the histologic pieces, because the way pathology works is that you take that histology and you either put in inflammation, in which case it will typically be an inflammatory process, or you can make one of the cell types malignant, in which case it will become a malignant process, right? And so in the kidney, this malignancy can arise from the tubules, it can arise from the blood vessels, it can arise from the interstitium. So you can theoretically, you could get an angiosarcoma of the kidney, you could get other types of sarcomas of the kidney, but because we're going to talk about kidney-specific things, we're obviously going to talk about the carcinoma of the kidney as well. So with that, we basically move on to kind of interrogating the functional unit of the kidney, which is the nephron, right? And so the nephron is basically comprised of the renal corpuscle and the renal tubule. So the Bowman's corpuscle or capsule is basically where it starts. You can see that this corpuscle composed of the glomerulus, and this is just a tuft of capillaries, right? And it's surrounded by a double-layered epithelial capsule, and that's known as the Bowman's capsule. So here, if we take a look at this in higher power, you can see that, you have to imagine this as a three-dimensional structure. So the vessels are coming towards you, towards you out of the screen and going behind the screen as well. But this is one cross section, right? And in that cross section, you'll see all these squiggly areas, and those are your capillaries. And once in a while, you'll see that the red cells are actually present in it, right? And that's basically because they were caught in the section. But the important thing to note is that there is obviously a point of entry for this stuff. There are lots and lots of capillaries in different loops, and then they go back. And this drains across this Bowman space, which is a space that has two epithelia. One is an epithelial lining on the glomerulus, the other one is the epithelial lining on the outside of the space. Here you will see that there is obviously a very complicated and beautiful mechanism for material to come out from the capillaries into the Bowman space, right? And that mechanism, having a basement membrane, having the podocytes, having the endothelial cells, and depending on where the problem lies, that's where many of the problems in renal pathology kind of work. So that's the corpuscle, right? But then we also have the tubule. So the renal tubule is divided into the proximal tubule, the loop of Henle. So here's a proximal tubule, then there's a loop, and then there's a distal convoluted tube, and this empties into the collecting duct. So the proximal convoluted tubule and the distal convoluted tubule are lined by a single layer of cuboidal epithelial cells. And the loop of Henle, which is this loop over here, or you can see it as this loop over here, it's composed of a thick descending limb. Can you see this? It's coming down here, sorry. And then it has a thin descending limb, then a thin ascending limb, and then a thick ascending limb, right? And so it's basically kind of what it looks like in this type of a cartoon. And it's really the collecting duct, which is at that point, it effectively has two types of cells: the principal cells, which are responsible for reabsorption and secretion of water and electrolytes, and the intercalated cells, which are responsible for the acid-base balance of the body. So histologically, it's actually pretty simple. Histologically, if you think about it, right, you're looking at these cuboidal epithelial cells. And so you can see these normal cuboidal cells, they look like little, cubes or squares, and they have a round central nucleus. And in the distal convoluted tubule, you can see that they're a little bit more closely packed. So it looks like they've got greater cellularity. And in the proximal convoluted tubules, they've got more abundant foamy cytoplasm. You can see these pink tufts, right, everywhere. And so that can kind of tell them apart, but at your level, I don't see any scenario where you would be asked to identify histologically the difference between the proximal and the distal collecting tube ducts, right? And so I don't think you should focus on that, but it's important to remember that histologically, it's actually pretty simple. You have the glomerulus. The glomerulus is a tuft of capillaries, right? And you can see a Bowman space. And then apart from that, you have the tubules that are all really tightly packed together. And normally when we show you an image, you see the tubules as round structures because the way the section has been taken, they're coming towards you, right, or going away from you. But in this particular image, you're seeing them as longitudinal structures because you're cutting them along the length of the tubule. So remember that when you're seeing an image, you might see the tubular epithelium as round, like a round structure, or you might see it as a long structure like this. And so here in this image, you can see those round structures here as well. So sometimes just because of the orientation of the tubule, you can see them in two different ways. So moving on, basically the pathologies that we're going to cover can broadly be defined by 4 subcategories, right? So you can have the nephritic syndromes, and broadly speaking, that will include your post-streptococcal glomerulonephritis, your IgA nephropathy cases, rapidly progressive or crescentic glomerulonephritis, and Alport syndrome. These are your nephritic syndromes. In contrast, you have your nephrotic syndromes, which include minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, amyloidosis, and diabetic glomerulonephropathy. In both these major buckets, right, nephritic and nephrotic, my recommendation to you would be to pick up on the 3 or 4 key features that, either present with this disease or that, we have like some telltale things like tram track sign or, spiky basement membrane. Like there's always going to be a buzzword, right? And so, of course, for high yield kind of step one responses, you have to remember the buzzwords because they're relevant. But for life, please understand the diseases in detail. You can also have diseases which have both a nephritic and nephrotic picture, right? So it's an overlap picture. So those include the diffuse proliferative glomerulonephritis, or the DPGN, or the membranoproliferative glomerulonephritis, or the MPGN, right? And so effectively in this, you'll see the features of both nephritic and nephrotic syndrome. And naturally, we cannot end our conversation without talking a little bit about tumors. And so we'll talk about renal cell carcinoma. Remember that this is not a complete and exhaustive list of all the entities that are part of the kidney system. And so please remember that this is just high yield. So, again, just to visualize this idea that nephritic syndromes, which we'll talk about next, and nephrotic syndromes have features, disease states that have both, and those are the DPGN and the MPGN, right? The diffuse proliferative glomerulonephritis and the membranoproliferative glomerulonephritis will have features likely that will be of both. But otherwise, I think for the sake of the questions, I think that the way the questions will be structured for you will be pretty pure in that it'll effectively be pretty clearly a nephritic or a nephrotic process. I'm not going to read out these entities to you again, but we'll just kind of talk about them now. So the idea of the nephritic and the nephrotic syndrome is that effectively you all can kind of think about the structure, which is the capillary. The capillary has proteins, which are shown as this kind of weird kind of orange yellow circle, and the red blood cells. And the important thing to remember is that the proteins and the red blood cells are all within this vascular space. Now, the vascular space is contained by endothelial cells, which obviously make the lining of the blood vessels. And then there's a basement membrane around it, and then there will be the podocytes, or the other cells that are outside. So the podocytes have these little foot processes, you can see, by which they talk to the basement membrane. And now when we are discussing nephrotic or nephritic syndrome, we're going to figure out what is leaking from this blood vessel and what is showing up in the urine, right? Depending on what shows up in the urine, you can kind of start making the buckets of nephritic versus nephrotic syndrome. So in nephritic syndrome, you mainly get red blood cells coming out. Okay, that's the, so if you get in nephritic syndrome, if red blood cells are the primary thing that are coming out, the patients will usually present with blood in the urine, right? So they will either have dark colored urine, right? These are the buzzwords, Coca-Cola colored urine, and so that's effectively how you will know that the presentation primarily is a nephritic presentation. We'll talk about nephrotic syndromes in the next section, but just to kind of introduce you, in the setting of nephrotic syndrome, it is mainly protein that will come out, right? So there will be a ton of proteinuria. There might be a few red blood cells, but really it will be primarily driven by protein coming out. So you might ask me, Dr. Mirza, well, that's weird, right? Because when you look at the protein here, it looks like it's smaller than the red blood cells. So if in nephritic syndrome, if the red blood cells are coming out, why isn't the protein coming out? Well, the answer is that it's a problem in these cartoons. Albumin and large proteinaceous structures are actually bigger than red blood cells in many cases. And so really red blood cells can come out, right? But there's a differential mechanism of how these things are kind of pushed out. And so the easiest way to remember this is thinking nephritic is red blood cells primarily coming out into the urine, or hematuria, and nephrotic is proteinuria with protein coming out into the urine. And then obviously if it's a mixed picture, you'll have both in pretty decent quantities in the nephritic-nephrotic syndrome overlap. So to recap, we're going back to nephritic syndromes, and nephritic is basically what we'll be talking about now. The concept of nephritic syndrome is that there is inflammation, right? That's what you kind of have to think about. Nephritic syndrome means that there's glomerular inflammation, which will mean that the glomerulus has inflammatory cells. Now, we know what inflammatory cells do. Inflammatory cells, by definition, will secrete different materials. They will try to destroy the things around it. And so as a result of that, there is damage to the glomerular basement membrane. Now, when the basement membrane is damaged and the glomerulus is damaged, patients will start losing red blood cells into the urine, and that will give the cardinal feature of hematuria, the cola-colored urine. In the urine, you'll see that red blood cells coming out will have dysmorphic features, which means that they will look abnormal, and they will also clump together in the tubules. So when they come out into the blood, they will come out as casts, which will mean tons of red blood cells stuck together, right? In this case, the other thing you'll try and interrogate is whether there is proteinuria or not. And the proteinuria will be less than 3.5 grams per day, which is in the subnephrotic range. By definition, what that means is that if you have over 3.5 grams per day of proteinuria, that's the nephrotic range proteinuria. So anything under 3.5 grams is still within nephritic range, right? So to recap, you have inflammation of the glomerulus, which leads to damage of the glomerular basement membrane, leakage of the blood cells, leading to hematuria. You can also get red blood cell casts, and proteinuria is subnephrotic if present. As a result of this, there can be a decrease in the glomerular filtration rate, which will lead to oliguria and uremic symptoms. And because renin will be increased as a response, patients will typically be hypertensive, right? So the picture that you're creating in your mind in nephritic syndrome is inflammation, hematuria, RBC casts, subnephrotic proteinuria, and hypertension, right? That's kind of how your patient will present. So again, to remind you, the afferent arteriole brings the blood in. It goes into all of these capillaries. There is the beautiful endothelial cell, the basement membrane, and then the podocytes, right? And so when you have inflammation here, you will basically get nephritic syndrome. Another thing to look at right now is that the mesangium is very nicely defined here. It's the central kind of portion, which has the interstitial cells. Nephritic, this is kind of fun to remember that there's an I in nephritic. So nephritic typically means inflammation. And remember that glomerular hematuria can be characterized by acanthocytes, right? Red blood cells are not in their normal environment. They're coming out in the urine. So there'll be all sorts of weirdo shapes. Remember that RBC casts and also acanthocytes is a feature of glomerular hematuria. So when you're getting it from the glomerulus, this is basically what it will look like. But if it's non-glomerular hematuria, let's say that the hematuria is from the urethra or something that's distal to the kidney, then you won't see the casts and you won't see acanthocytes. So it's important to remember that when you're reviewing patients' urine and it has blood in it, there is a mechanism to be able to tell whether it was glomerular hematuria or non-glomerular hematuria. So the first entity within the disease states of nephritic syndrome is post-streptococcal glomerulonephritis. This is a type 3 hypersensitivity reaction because patients typically have group A beta hemolytic strep pharyngitis, or they could have skin infection. So what's happening is that they're getting infected with group A beta hemolytic strep. Typically, these are children. And as a result of that infection, a couple of weeks later, you will find that there is an immune response, a type 3 hypersensitivity immune response that leads to immune complex deposition and in the kidney that activates the complement, and the patients will, because of that activation of complement, have a consumptive hypocomplementemia, which means that their complement factors will go down because they're being used because of complement activation. So in light microscopy, this is a reminder for you to see the normal glomerulus, which is showing the Bowman space, the capillary, the podocytes, and the mesangial cells. And in contrast, in post-streptococcal glomerulonephritis, you will have an enlarged renal corpuscle, right, which is shown by the dotted line. And it'll actually be full of lots of different cells. One is that there'll be an endothelial proliferation. That's showing you lots and lots of endothelial cells, which are shown by the yellow arrowheads. And also, it's looking busier. When you look at it, it looks like there's lots of nuclei, and that's because there's an inflammatory infiltrate, which are typically neutrophils, and those are shown by the blue arrows. And so here you can see that all of those features combined give you group A based hemolytic strep pharyngitis, which led to type 3 hypersensitivity that led to post-streptococcal glomerulonephritis. The key feature here is also that immunofluorescence, when we study by fluorescent antibody stain, will show you a starry sky or a lumpy, bumpy appearance, because what's happening is that there's IgG, IgM, and C3 deposition within the subepithelium of the kidney, right? So there's subepithelial deposits, and they can be seen as these subepithelial humps. So you can see that there's epithelium, and beneath the epithelium, you can see that there are subepithelial humps, right? So they're underneath the foot processes. So this is post-streptococcal glomerulonephritis. To quickly recap, it's a nephritic syndrome. It typically presents in children who've either had the pharyngitis or skin infection with group A beta hemolytic strep. A couple of weeks later, because of a type 3 hypersensitivity reaction, these immune complexes go into subepithelial locations within the kidney glomerulus, and they cause these subepithelial humps. The H&E looks like it's full, like with lots of inflammatory cells and endothelial hyperplasia. And by immunofluorescence, you get a lumpy, bumpy pattern, which is because of IgG, C3, or IgM deposition. And those are your key features. The second nephritic syndrome we're talking about is IgA nephropathy or Berger's disease or Berger disease. This is an asymptomatic microhematuria with intermittent gross hematuria. And this either happens during or after a respiratory or GI tract infection because we know that IgA is secreted by mucosal linings. Because of this, what will happen is that there will be a mesangial proliferation. Remember, mesangium was that central area which we saw on that cartoon. And the mesangial IgA immune complexes will deposit and can be seen on immune fluorescence. So here is the picture. You have an abnormal IgA1, and the anti-glycan autoantibody binds to it, and then this can go and deposit in the mesangium. It activates the alternative complement pathway and leads to glomerular injury. And remember, injury or inflammation is effectively the hallmark of nephritic syndromes. And as a result of that, the inflammation will lead to the hematuria, which in the case of IgA nephropathy is microhematuria. And what's very important to remember is that it's intermittent gross hematuria, which means that patients will have bloody urine, and then for a while they'll be totally normal, and then they'll have it again. So it's intermittent. So that, I think, is a very characteristic history for IgA nephropathy or Berger's disease. Alport syndrome is also a nephritic syndrome. This one is an X-linked dominant progressive disease that typically manifests during adolescence. It is because of a type 4 collagen mutation that leads to alterations of the glomerular basement membrane. The thing to remember here is that patients will have visual effects, urinary problems, and hearing problems. So remember, can't see, can't pee, and can't hear B. And this is because of retinopathy due to lens dislocation, glomerulonephritis, and also sensorineural hearing loss. The other feature here, the buzzword to remember, is a basket weave appearance on electron microscopy, where the glomerular basement membrane is lamellated, and it's because of longitudinal splitting. So here's Alport syndrome. You can see in this cartoon that this is the basket weave appearance of the basement membrane, which is this purple colored thing. And in electron microscopy, here is a nice, beautiful, normal basement membrane, which is shown here as abnormally thin, just as a contrast. And in this one, you can see it's abnormally split and lamellated in this basket weave kind of way. So to recap, Alport syndrome is a nephritic syndrome, which is X-linked dominant due to a type 4 collagen mutation that leads to glomerular basement membrane alteration that is basically a basket weave or kind of an abnormally split and laminated GBM. Patients will present with eye problems, urinary problems, and hearing problems because of the presence of the type 4 collagen mutation affecting basement membranes in all of those locations. And this is a nephritic syndrome. Membranoproliferative glomerulonephritis, or MPGN, was actually one of the nephrotic overlap ones, so we're going to talk about it here. The type 1 membranoproliferative glomerulonephritis is basically the immunoglobulin-mediated membranoproliferative glomerulitis, and you typically think of this as secondary to either HBV or HCV infection, right? So Hep B or Hep C infection. Type 2 membranoproliferative glomerulonephritis is complement-mediated MPGN, and this is associated with IgG autoantibodies that stabilize C3 convertase, that is C3 nephritic factor, and that leads to persistent complement activation that causes a decrease in C3. So in light microscopy, you have a tram track appearance. This tram track appearance basically shows up because the glomerulus has increased mesangial cellularity, which is the circles. And then there's duplication of the glomerular basement membrane as a double contour of the GBM, which is shown by the yellow lines. So here, you can see here, there's a double line here of the basement membrane, and this is highlighted by the yellow lines here. And this is the tram track appearance. So remember, membranoproliferative glomerulonephritis is a nephritic syndrome or a nephrotic syndrome, but remember that this will have a tram track appearance on light microscopy. On electron microscopy, type 1 MPGN, which was the immunoglobulin-mediated one, will have subendothelial deposits, and type 2 will have intramembranous deposits, which is also known as dense deposit disease. In contrast to membranoproliferative glomerulonephritis, sorry, I went back by accident. Diffuse proliferative glomerulonephritis, you typically think of in patients with systemic lupus erythematosus. And basically, you can, as I've told you before, DPGN, which is diffuse proliferative glomerulonephritis, or membranoproliferative glomerulonephritis can often present as both nephritic and nephrotic syndromes concurrently. Even in DPGN, you'll have decreased C3 complement levels, and because the patients will basically have SLE or SLE-related diseases, they can have anti-nuclear or anti-double-stranded DNA antibodies. On light microscopy, what you're going to see in diffuse proliferative glomerulonephritis is that there's a proliferation of both the mesangium and endothelial cells. So there are lots and lots of these proliferative cells, and you get thickening of the capillary walls, and they can appear as wire loops. So then we move on to rapidly progressive crescentic glomerulonephritis. And the reason I'm talking about this after the DPGN and the MPGN is because it could be because of those diseases as well. Rapidly progressive or crescentic glomerulonephritis will give you a crescent-shaped inflammation within the glomerulus or the Bowman's capsule. This has multiple causes, and it could also include such things like a type 2 hypersensitivity reaction, which is in Goodpasture syndrome. Overall, crescentic glomerulonephritis has a poor prognosis, and on immunofluorescence, you can either see a linear pattern, which is what you'd see in Goodpasture syndrome, a granular pattern, which would be either because of the post-streptococcal glomerulonephritis or the diffuse progressive glomerulonephritis. You can also have negative immunofluorescence in which there's no immune-mediated product seen, and this is seen in post-C immune crescentic glomerulonephritis. The cases of post-C immune could include granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. On light microscopy, you see a hypercellular crescent-shaped zone, which is highlighted in this blue overlay. You can see this. It's like a little crescent around. So basically, it's filling up the Bowman space. And this is an inflammatory infiltrate, and that inflammatory infiltrate is highlighted by the blue arrows. So those were your nephritic syndromes, right? And so remember, nephritic syndromes primarily present with hematuria due to inflammation, and then they ultimately can also have patients who have hypertension, and we're going to do some of the clinical cases, and so you'll be able to remember. I also covered the two entities of nephritic, nephrotic under the nephritic headline. But now we're going to change gears and talk about nephrotic syndrome. Nephrotic syndrome here is shown on the right, and primarily in contrast to nephritic, where hematuria was the problem. In this case, proteinuria is the issue, and we've already defined that the cutoff for nephrotic levels proteinuria is 3.5 grams per day. So they do a 24-hour urine collection, and they measure the amount of protein, and if it's over 3.5 grams, that's nephrotic range proteinuria. So similar to how we talked about the pathophysiology of nephritic syndrome, nephrotic syndrome pathophysiology is podocyte damage. So the podocytes in this case are being damaged. These are the cells that have the foot processes. This causes an impaired charge barrier because of the fact that they are obviously on the other side of the receiving end of the material that is crossing the basement membrane. And this leads to a massive proteinuria over 3.5 grams per day. The loss of the negative charge of the glomerular basement membrane loses that selectivity, especially for the negatively charged albumin, and that's why selectively albumin will come out more. When you have a decrease in serum albumin because you're losing it in the urine, there will be lots of edema because, a bunch of the oncotic pressure of the blood is because of albumin. So these patients will have proteinuria and edema, and because of the fact that they'll be losing antithrombin 3, protein C, and protein S, they'll also have hypercoagulability. In contrast, there will be increased levels of plasma cholesterol, LDL, and triglycerides, and this is because they're trying to compensate for the loss of albumin to keep up the oncotic pressure. This will lead to lipiduria because lipids will also spill through into the urine, and there will be fatty casts, which basically means that there'll be casts of fat seen in the urine. In contrast to in nephritic syndrome, you were seeing red blood cell casts. These patients will also be losing immunoglobulins, right? Those are also proteins, and that can increase the risk of infection. So the first one is minimal change disease. Minimal change disease is the nephrotic syndrome, which is the most common cause of nephrotic syndrome in children. It's associated with the 4 I's: idiopathic, immune-mediated, infection, or immunization. And it can also be secondary to tumors such as Hodgkin lymphoma or certain drugs such as non-steroidal anti-inflammatory drugs. So what will happen in minimal change disease is that on light microscopy, you will see nothing, right? It's minimal change. Then the kidney will be biopsied. This will typically be a patient that has proteinuria, and as a result of that will be edematous, right? Will have hyperlipidemia and lipid casts in the urine. But when you do the kidney biopsy, it'll be normal. There'll be an intact glomerular basement membrane. There'll be no mesangial proliferation. The visible capillary lumens will have no vascular changes. But when patients look at electron microscopy, what you find is that there's effacement of the podocytes, right, which is shown in the green circles. So the podocyte foot processes are kind of effaced or blunted. And then there's also swelling of the podocytes as well. And to recap, minimal change disease is a nephrotic syndrome. It's caused because of either idiopathic reasons or immune-mediated things or infections or drugs. And when you look at the light microscopy, there's nothing to actually see. But on electron microscopy, you see effacement of foot processes. The second nephrotic syndrome is focal segmental glomerulosclerosis, or FSGS. This is the most common cause of nephrotic syndrome in adults. And these are important things to remember, right? If it's a child, the most common cause is minimal change disease. If it's an adult, the most common cause is FSGS. This is associated with either heroin abuse, HIV infection, sickle cell disease, or obesity. Patients can also be undergoing interferon treatment or have congenital malformations that lead to the creation or a situation where they can get FSGS. On light microscopy, remember that this is focal and it's segmental, meaning that in the glomerulus, it will be focal glomerulosclerosis. The glomeruli will look very sclerotic and they'll look very, very pink, but it won't be the entire thing. So the focal segmental means that it's going to be part of the glomerulus, and it won't be every single glomerulus because it'll be segmental, right? And so here what you'll see is that when you take a biopsy, you'll see these foci in some segments of the kidney that will have this glomerulosclerosis. And in this glomerulosclerosis, you'll see in the perihilar region, these purple overlaid areas, you can see this hyaline deposits, and you can see sclerosis is also present, right? And so this dark pink area is sclerosis. So when you look at this, it doesn't look diffuse sclerosis. It looks like it's focal sclerosis. And then it's in some segments of the kidney. So this is FSGS, focal segmental glomerulosclerosis, most common cause of nephrotic syndrome in adults. Remember, heroin use, HIV infection, sickle cell disease, obesity, and interferon therapy. Membranous nephropathy is also a disease of with nephrotic range proteinuria. This is typically because of antibodies to phospholipase A2 receptor. It's secondary to infections, including hepatitis B, C, or syphilis. It could also be due to drugs or different types of tumors or SLE. But the important thing here is that on light microscopy, what you see is diffuse thickening of the glomerular basement membrane. This is being highlighted by the blue overlays in this area, but basically the capillaries are thickened and the glomerular basement membrane is thickened. So there are some findings on light microscopy. On electron microscopy, you see in the yellow outlines the thickening of the basement membrane. And what's happening is that there's spike formation because of subepithelial deposits. And so what you're seeing here, especially here with this blue arrow, that you can see that there's spikes coming out of black. The spikes are because in between the spikes, there are all of these subepithelial deposits. So as a result of that, it looks like it's a spiky appearance because of the deposits in between. So one of the buzzwords to remember is a spike and dome appearance with the spike formation is classic electron microscopy finding for membranous nephropathy, which on light microscopy has diffuse thickening of the basement membrane. We would be remiss not to talk about amyloidosis. Amyloidosis can affect the kidney. It's actually the most commonly involved organ. Remember that amyloid deposition is associated with chronic inflammatory disease such as rheumatoid arthritis, in which case it will be AA amyloidosis, or it could be multiple myeloma or plasma cell dyscrasias, in which case it would be AL amyloidosis. Patients can also get amyloidosis with prolonged dialysis. On light microscopy, you'll actually see this is a Congo red stain, which is showing you this kind of orange-pink appearance because of the Congo red. But really, like if it was just H&E, you'd see this kind of amorphous pink, fluffy kind of material with no nuclei in it. The important thing is to be able to do polarization of this stain, and then you get this apple green birefringence of this Congo red stain, and that proves that this is amyloidosis, and then you can send it for mass spec and see what type of amyloid it is. Diabetic glomerulonephropathy is also a nephrotic syndrome. It is the most common cause of end-stage renal disease in the United States. What happens in patients with diabetes is that there's obviously chronic hyperglycemia that leads to a non-enzymatic glycation of tissue proteins, right? So glycation is happening everywhere. They get HbA1c because of glycation, they get all sorts of neuron damage because of and vascular damage because of glycation, but it's also glycating the tissue proteins that leads to a mesangial expansion. Ultimately, there's a glomerular basement membrane thickening, and there's an increase in permeability. Because of that, there's hyperfiltration of the GFR, right? The glomerular filtration rates increase. There's increased interglomerular pressure, and that there's progressive glomerular hypertrophy and an increase in kidney size, while also scarring of the glomeruli. And ultimately, this is worsening of the nephropathy. So what you're going to see here is the characteristic Kimmel-Steele-Wilson nodule, or the KW nodules, which is also called nodular glomerulosclerosis. So you can see these nodules here. These are the Kimmel-Steele-Wilson nodules. You can see this, but this is different from FSGS. One, it's because this patient is diabetic, so you're going to think of this. Second, this is not focal segmental. This will be kind of everywhere in every part of the kidney, but it'll be nodules within every glomerulus. The other thing which is important to note in this particular image is that there is a hyaline arteriosclerosis. This is the blood vessel which has arteriolosclerosis here as well, which is highlighted by the purple overlay. So diabetic patients will get this KW nodules. They can also get proteinuria and effectively have nephrotic syndrome. Lastly, renal cell carcinoma. This is the most common primary renal malignancy. It is because of the proximal convoluted tubule. Basically, that's the cell of origin. There's tumorous change in the proximal convoluted tubules, and this can obviously cause an expanding tumor. This tumor can invade the renal vein that can go via the inferior vena cava and hematogeneously spread, including going to the metastasis into the lung and bone. The thing to remember about renal cell carcinoma is a triad of flank pain, palpable mass, and hematuria. And you can get associated paraneoplastic syndromes, which have the acronym PAIR for PTRHR type peptide, ectopic EPO, erythropoietin, ACTH release, and renin release. Clear cell renal cell carcinoma is the only one I'm going to show you. It's the most common subtype, and it's shown here. It's associated with gene deletion on chromosome 3, right? So this could either be sporadic gene deletion, or it could be inherited as in von Hippel-Lindau syndrome as well. So here what you're seeing is you see nests of these cleared out cells, tiny little nuclei, lots of open space of clear cytoplasm, which is full of lipids and glycogen. And that's kind of showing you, with these overlays, and the tissue is really vascularized. So you get this chicken wire type vasculature, and you can see that with the arrowheads here as well. So with renal cell carcinoma, remember it's originating from the proximal convoluted tubule. Remember that it has this clearing of the cytoplasm. Remember it's the most common primary renal malignancy. And importantly, remember that it is associated with gene deletion of chromosome 3. And this could either be sporadic or inherited as part of the von Hippel-Lindau syndrome family of tumors. So this is the second review we're doing, and we have approximately the same number of people. And I loved the interaction last time, and so don't be shy, when we do these questions. Hopefully it'll give you lots to kind of think about, but, answer these questions. I'll open up the chat, so we'll talk about it too. So I'm going to read out the question and ask you obviously what the answer is, but also kind of what you're thinking. I'm happy to kind of discuss with you, even if we go a few minutes over. So this picture is actually a picture from the lecture, so you should immediately be able to look at it. Even when I'm not reading the thing, you should be able to see that it looks a little bit more full, it looks a little bit big, it looks like there's an endothelial proliferation, and that looks like there are inflammatory cells here as well, right? So that's kind of where we start. I'm going to open up the chat. All right, someone is already answering the question. So a 21-year-old male presents with dark urine and reduced urinary output persisting for a span of 48 hours. So what's that telling you? It's telling you that it's a young person and there's hematuria. 3 weeks ago, he underwent antibiotic therapy for a skin infection, which I'm obviously giving you because that effectively is the reason for the question. So there's bilateral periorbital edema, and his blood pressure is 142/90. Renal biopsy is shown. Further evaluation of this patient is most likely to show which of the following findings. So a bunch of you are getting it right. The answer is, and I'll tell you what it is. What's the disease? Let's start there. Okay, so post-streptococcal glomerulonephritis is the answer, right? So I know a bunch of people are writing different things. Remember, he has a skin infection. Now he had, a couple of weeks ago. Now he has hematuria, right? Because of that, and you're looking at the inflammation and effectively, and he has a little bit of an increase in blood pressure. He also has reduced urinary output. So a type 4 collagen mutation is not seen in post-streptococcal glomerulonephritis. Proteinuria of 3.5 grams a day would be nephrotic range. Elevated anti-DNase B is basically evidence that he had the streptococcal infection. So that's the answer. You're not going to get mesangial IgA, and you're not going to get decreased. So everyone who said C and post-streptococcal glomerulonephritis, you were correct. This is literally the picture from the case as well. So, when you look at the recording, you can go back and you can take a look at that. A 22-year-old woman comes to the office for evaluation of joint pain, fatigue, and edema for the past month. She has a history of oral ulcers. Blood pressure is 130/80 and pulse is 80 per minute. Swelling, erythema, and tenderness are noted over her hands. 24-hour urine protein excretion is 4.5 grams. Serum anti-nuclear antibodies are present. Renal biopsy shows glomerular capillary wall thickening. When stained with methenamine silver, irregular spikes protruding from the glomerular basement membrane are seen. Which of the following is the correct diagnosis? So the first thing that you have to figure out is this nephrotic syndrome, or is it a nephritic syndrome, right? So tell me, what is this? Is it nephrotic or is it nephritic? Very good. It's nephrotic. So she's got nephrotic range. Proteinuria is 4.5 grams. So it's all nephrotic. Very good. And the silver stain is showing you the spikes. So remember, I told you the spikes are when you have subepithelial deposits, and that's why it looks like spikes. So what's the answer? A bunch of you have already given it. The answer is E. Excellent. All of those who got it, this is membranous nephropathy. Very good. Next question. A 42-year-old man comes to the physician because of leg edema over the past 2 months, right? So remember, we're already talking about edema. We're not talking about hematuria. He reports frequent numbness of the fingers and cramping of leg muscles. He is being treated with combined antiretroviral therapy due to the history of HIV infection. So this is a patient with HIV. His blood pressure is a little up, 150/90, and physical exam shows 3+ periorbital and lower extremity edema bilaterally. Lab studies are shown, and which of the following findings would be seen under light microscopy of a renal biopsy? Would it be thickened glomerular capillary loops? Would it be nodules within the glomeruli? Would it be no change? Would it be segmental sclerosis or enlarged and hypercellular glomeruli? Many people are getting it. Excellent. It is D. So what's the disease? FSGS, very good. So FSGS, remember, FSGS was the most common cause of nephrotic syndrome in adults, and it's also associated with HIV, right? So the thickened glomerular capillary loops takes you down a completely different road, right? He doesn't have diabetes that we know of, right? Otherwise, that would be nodules. He doesn't have minimal change disease, which would have no changes, and he doesn't have enlarged or hypercellular glomeruli because he basically have very good question, Jess. Jess is asking about fibrosis and sclerosis. It's a really good question. So remind me, I'm going to get through these questions and I'm going to try to address that. Maybe for step 1 level, you may not need to know the difference, but we'll talk about it. Yeah. It's a good question, though. Jess, you should become a pathologist. All right, 15-year-old boy presents with occasional blood in the urine. It first occurred 1 year ago during an upper respiratory infection and resolved spontaneously. You should know the diagnosis already. So 15-year-old boy is having intermittent hematuria. Boom, right? There's an answer there, right? He also had a similar episode about 5 months ago, which also resolved. Vital signs are normal. On lab evaluation, BUN is 14 milligrams per deciliter. Creatinine is 0.8. Which of the following findings is most likely to be seen on microscopic evaluation of a renal biopsy, right? So intermittent is what you have, and everyone is kind of getting it, which is really, really good, right? This is mesangial deposition of IgA. He had the upper respiratory infection, which is amazing because this is obviously a fake history, so you get that, right? But the epithelial linings and IgA, and after that there is intermittent blood in the urine. So this is IgA disease, mesangial deposition of IgA. 12-year-old boy presents with dark urine, problems with vision, and hearing loss. You should get the diagnosis immediately, right? The idea is that this is can't see, can't pee, can't hear, B, right? He recovered from a viral upper respiratory tract infection 2 weeks ago. Temperature is 99, blood pressure is 140/90, pulse is 75. Physical exam shows anterior lenticonus and sensorineural hearing loss. Urinalysis demonstrates dysmorphic red blood cells and red blood cell casts, which proves to you that this is glomerular hematuria and not non-glomerular hematuria. Electron microscopy is shown below. Which of the following is the correct diagnosis? The answer is C. Very good. 7-year-old boy reports progressive swelling of the hands and feet over the past 10 days and that his pants feel tighter than usual, right? So he's got edema. 2 weeks ago, the patient was treated for anaphylaxis following a bee sting, okay? Examination shows pitting edema of the hands and feet, mild ascites, and periorbital edema. Renal biopsy would most likely show which of the following findings? Excellent, you guys got it. So is it a cellular proliferation in segmental areas? That would be FSGS. Doesn't seem like this is the right one. Is it crescentic formation? This does not look like crescentic. Is it diffuse thickening of the glomerular basement membrane? Probably not. Cellular proliferation with increased neutrophils and capillaries, or a normal histology. So everyone who got E, that is the right answer. This is minimal change disease. A 12-year-old boy is brought to the physician due to periorbital edema for the past 3 days and dark urine. Okay. 3 weeks ago, he was treated for bacterial tonsillitis. His temperature is 99.7, pulse is 76 a minute, and blood pressure is 157/85. Lab studies are shown. A renal biopsy would most likely show which of the following findings. So here, when you take a look at this looks like the lumpy, bumpy appearance on immunofluorescence, right? You need to pick that up. Now that we say lumpy, bumpy, everybody's going to get the right answer. Good job. So this is not spike and dome. This is not mesangial IgA. This is granular deposits of IgG, IgM, and C3. What's the disease? Very good. Post-streptococcal glomerulonephritis. Excellent. All right, a 65-year-old man with a 40-year back year history of smoking presents with right costovertebral angle pain, hematuria, and fever. CT of the abdomen demonstrates a contrast-enhancing lesion of the kidney. A renal biopsy is shown. Which of the following is true? So what's the disease? Yeah, you guys get the answer. Very good. It's RCC. It's renal cell. It's clear cell renal cell carcinoma. Everybody can see that, and it's associated with gene deletion of chromosome 3. And with that, let's talk about Jess's question of sclerosis versus fibrosis. So, I don't know. I know, but it's very difficult for me to explain. All right, so fibrosis is the process of healing with scarring. So fibroblasts will lay down material and cause the process of a scar formation. Sclerosis is a very similar process, but typically it just shows up as being different. So I would say for practical purposes, at your stage, I would say sclerosis and fibrosis is the same, right? So I wouldn't make a difference between it, but just go with, like, for example, in the heme lecture yesterday, we talked about nodular sclerosis. Nodular sclerosis a Hodgkin lymphoma, right? That's sclerosis. But really, when you look at it, it is a type of fibrosis. It may be the type of cell and what type of collagen it's laying down, but I think for your purposes, Jess, I think it was Jess who asked the question. You should probably think of it as the same. For how long after the initial infection can you have hematuria for IgA nephropathy? I'm actually not sure, but I think that it's because it's intermittent. It can be for a while, but I'm not sure if there's an actual cutoff. So why do you have intermittent hematuria? I actually don't know. I'm not sure why there's intermittent hematuria. I don't know the physiology of why it is, but that's basically the thing that the IgA will present with. You're welcome. You're welcome. All right, that's it. I think that the questions are finishing up. Any other questions?
Perfect. Thank you, Dr. Mirza. That was truly amazing. And thank you, everyone, for your interaction in the chat. Please stay tuned for our future virtual PathSig events.
Take care, everyone.